Good morning, everyone. My name is Jenna Webb. I work with Saskatchewan Health Authority Communications, and I will be moderating the news conference this morning. We are using WebEx events for the briefing today. All participants will be on mute. There will be an opportunity for questions at the end of the presentation, and I'll give you further instructions on that at the appropriate time. If you do not have video enabled on the call this morning, the news release and PowerPoint presentation are available on the Government of Saskatchewan website. We'll begin with the presentation, and with that, I'll turn it over to our CEO, Scott Livingstone, to kick things off.
Thanks, Jenna. I'd like to acknowledge that I'm joined here today with Dr. Shaw, our Chief Medical Officer, and on video conference in Saskatoon by Mr. Derek Miller, our Commander of the Emergency Operations Committee, Dr. Jenny Bazaran, our Senior Medical Information Officer, and Dr. Julie Krasnowski, Senior Medical Health Officer. We're taking a team approach to today's presentation because the challenges that COVID-19 has given us takes a team approach to attack. Our team of staff and healthcare providers is more than 44,000 strong, and we know that they're all working flat out to serve the public through this difficult situation. So I want to thank them sincerely for all their hard work and sacrifice. Today we'll take you through an in-depth presentation of the modeling data on the potential impact of COVID-19 in Saskatchewan. It's critical to remember that this data is not for prediction of the future. It's data that acts as a planning tool to ensure that we're preparing for the worst, but aiming for the best. What we do know at this point is that our health system strategy for COVID-19 has already paid dividends. Public health measures are already starting to show encouraging signs of flattening the curve. The slowdown of non-essential services across the province has already enabled us to create 40% more capacity in our hospitals across the province to handle future surges of COVID-19. But to ensure that we're prepared for the worst case scenario, we need to do more. This presentation, you will hear that we are taking continuing action on testing, contract tracing, population health measures that will continue to make a difference in Saskatchewan. We have a plan to drastically scale up acute care capacity, which will be required to meet the patient demand and safety for both COVID and non-COVID patients. We know that when we share this data, there will be inevitable questions and concerns about the capacity in our healthcare system. The reality is, whether we have enough resources or capacity is up to you. We'll say it again and again that there is no healthcare system in the world that can flatten the curve on the growth of COVID-19 without the help of the public. Wash your hands regularly, stay home whenever and wherever possible, practice physical distancing, and abide by all isolation and gathering restrictions. We know from our data that the vast majority of Saskatchewan residents are doing these things. So we want to thank the people of Saskatchewan for your ongoing support to confront COVID-19 pandemic. But we also ask you to continue. We're asking people to stay safe and do your part to save lives and protect our healthcare providers. With that, I'd like to hand things off to Derek Miller to kick off our presentation.
Thank you, Scott. There are two key elements of the purpose of our response to COVID-19. The first is that we need to adapt and expand to meet the projected COVID-19 patient demand. And the second is that through that, we need to be able to continue to deliver the essential services to non-COVID-19 patients. And we need to do both of these throughout the duration of the event. Today, we're going to walk through the modeling information that's been used to inform our plan. And then we're also going to touch on how the SHA is positioning an offensive strategy through population health, public health, and community care, and also a defensive strategy, which looks more at our acute services. And then there will be time for questions. I'll start off by turning it over to Dr. Jenny Bazaran, our Senior Medical Information Officer, to review the dynamic modeling results for COVID-19.
Good morning. Thank you. The Saskatchewan Health Authority partnered with Dr. Nathaniel Osgood and the Computational Epidemiology and Public Health Informatics Lab at the University of Saskatchewan to do this modeling. We also had additional support from Dr. Maureen Anderson, as well as our colleagues at Health Quality Council. Next slide. So an introduction to dynamic modeling. This type of modeling that we chose to use helps assess the impact over time of various what-if scenarios. So COVID-19 is a novel coronavirus where we have no experience in the past with which to learn from and apply specifically to the Saskatchewan situation. So the dynamic modeling allows us to look at learnings that we have from other jurisdictions and the evidence that's coming through to really look at how could COVID-19 transmit in our population, what would be the impact of various public health interventions, and the subsequent impact on the acute care demand. It is not a predictive model, as Scott has already alluded to, but it does provide information to support both the response and the preparedness, and that was our key priority in using the dynamic modeling. The dynamic models will continuously be updated as we learn more both about COVID-19 and as we get more specific data from the Canadian and Saskatchewan experience. Next slide. One of the key variables that we use when we're doing dynamic modeling is something called the basic reproductive constant. And this is really the average number of people that one person with COVID-19 would infect in a population of all susceptible individuals. So for example, if I were to get the COVID-19 infection and the reproductive constant was 3, that means if I get it, I would infect 3 people, and those 3 people would infect 3 more people. And within 10 cycles, you'd have 58,000 people infected. So it's a very key variable in the spread of COVID-19. For our modeling scenarios, we chose to look at a low, medium, and high range of possible scenarios to help identify what the situation potentially, how it might potentially impact our province. I will go through each of those in more detail in the next slides. It is important to remember in the numbers that we provide that these are the individuals that are specifically COVID positive, and that we do not account currently for those that are currently using the hospital capacity, the non-COVID patients. This is a slide showing the current COVID-19 case count. This is purely a case count, and it would reflect, of course, the number of people in each of the different jurisdictions that we're showing now. Saskatchewan and Manitoba, as you can see, are towards the bottom of the graph, with Saskatchewan with the green line to identify the case counts that we have to date. The next slide shows a more relativity to the size. It's the number of case counts per 100,000 people. And here you can see that Saskatchewan is also early on in the transmission of the disease and the case counts that we have identified. And part of this is influenced by the number of tests that we've done, and Saskatchewan has indeed done more per capita than many other jurisdictions that we've compared ourselves to here. Next slide. So the first scenario that we chose to model out to show the high range was what we used a reproductive constant of 4.0. And that number came from the modeling lab has the ability to do advanced analytics, including particle filtering and other methodologies. And they were looking at some of the Canadian data, and there was a signal to suggest that the R0 potentially could be at 4.0. And we've heard similar comments from our colleagues across the country. So we use this as our highest range scenario. And where our starting point is with the modeling is the assumption that we are continuing with our current levels of COVID-19 measures. In this scenario, in the high range scenario, if it were to be applied to our province, at the peak of the epidemic, there would be 4,265 approximate patients with COVID-19 that would require to be in the hospital at the same time. Of those hospitalized, 1,280 of these COVID-19 patients would require ICU admission, with 90 to 95% requiring ventilation. Next slide. In the second scenario, we chose to use the reproductive constant of 2.76. And this number was chosen from the experience of low Italy. So we did not model high Italy specifically, which is the area of Lombardy, which has the very, very high numbers. The experience that we've modeled here is in a different area of Italy where they had a bit more time to prepare, and the impact wasn't as severe. And we felt that it potentially could represent a situation here in Saskatchewan. So again, the modeling assumptions that we've included in the model are that we are continuing with our current levels of measures. In this scenario, at the peak, we would have 1,265 COVID-19 patients simultaneously requiring acute care hospitalization. Of those hospitalized, 380 of those would require to be in the ICU, with again 90 to 95% requiring ventilation. Finally, in our third scenario, we chose the reproductive constant of 2.4, which is what was the experience in Wuhan, recognizing, of course, that their experience was quite unique, both in that they were the first ones to experience this and the level of interventions that they applied. This is also the one that is used in the imperial model for those that have been following the modeling literature as well. Again, the beginning assumption is that Saskatchewan continues with our current level of COVID-19 measures. As you can see in this scenario, at the peak, it is a lot less. There are 390 COVID-19 patients that would require to be in an acute care hospital at the same time. Of those hospitalized, 120 of those would require to be in the ICU, with 90 to 95% requiring ventilation. The next slide shows a summary of these three different scenarios, including the cumulative total cases and the cumulative total deaths. Again, this is not predicting what will happen in Saskatchewan. This is applying those numbers in that situation to Saskatchewan. It is too early for us to know the exact scenario that we're in Saskatchewan, and will really depend on how well we are all complying with the Chief Medical Health Officer interventions. Next slide. These are graphs again demonstrating and summarizing the data that was in those tables. The top graph is the cumulative COVID-19 cases. The black line identifies if we had done no interventions. The red line is the upper range, the yellow is the mid-range, and the green is the low range. Again, currently, we are not sure where we are in that trajectory, but it gives us a sense of the impact of the population. The bottom is the three scenarios again for deaths. And again, we don't know where we are on this curve. And of course, our anticipation and our hope is that we are doing even better than this. Next slide. These two slides show the impact of COVID patients in hospital as well as those in ICU. This is very similar to the graphs that have been out in the public with flattening the curve. The black line shows us if we had no interventions, our hospital projections would be quite high. And as the range of projections goes down, we are flattening the curve with different different scenarios. Next slide. So the key message here is that dynamic modeling isn't a prediction. We are not predicting that these are the numbers, but it does provide us a range of what-if scenarios. If this were to happen in Saskatchewan, what would the numbers look like, and how would we plan both our public health response as well as our acute care planning? We do see from the charts that current interventions have made a difference, and that's really a key thing to identify. But that the most important variable for us to save lives and to protect healthcare workers is really the public's compliance with isolation measures, physical distancing, and washing your hands. I'm going to pass it over to Dr. Krasnowski to describe this in more detail.
Thank you. So I'm Dr. Julie Krasnowski, SHA Senior Medical Health Officer, and I will talk through the components of SHA's offensive strategy in our response to COVID-19. Next slide, please. So as we enter in a new month and look back since the first cases of COVID-19 were reported in Saskatchewan about 1 month ago, I think the reality is hitting home. We are not immune, and in the weeks and months to come, we can expect to see more cases of illness and indeed more deaths. We are learning from the experience of other provinces and from around the world, and the modeling scenarios are based on our best knowledge at this time. And as we go forward, we'll continue to be updated with Saskatchewan-specific data. My takeaway is that the models underscore the importance of aggressive and sustained public health measures and population health approaches that can help us flatten the curve. Next slide, please. In our planning, the SHA has based our response to COVID-19 on a strategy that includes containment, delay, and mitigation, but on a foundation of population health promotion. Taking a population health approach is important because it helps us look at the distribution of risk and protective factors and the direct and indirect impacts of COVID-19 across different population groups. We know that individuals and communities will be affected in different ways, even though the pandemic involves everyone. And our goal as a health system is to be promoting health, preventing disease, and ensuring that healthcare services continue to be available when and where needed most. Next slide, please. Some of our key strategies for our public health response include increasing testing. Indeed, Saskatchewan is among the provinces with the highest per capita testing rates, and to date we've performed more than 14,000 tests. Our testing strategy helps us to identify cases early and distributed within the population so that we can respond appropriately. Each case requires a case investigation and a contact investigation, and we've expanded our capacity to do that work with more than a 300% increase in staffing. Another key component is enforcing adherence to the Chief Medical Health Officer orders that are in place. This is the work of our public health inspectors in partnership with law enforcement officials. And we are also investing in data tools that will help us manage all of this work of case cluster and outbreak investigation and response. Next slide, please. In the community, we are making more primary care services available to people through expanding Healthline 811 with more than 250 new staff trained. We are also delivering more services through virtual care models, which include video conferencing and telehealth options with more than 750 clinicians set up to provide services in this way. And we are opening testing and assessment centers across the province. We have 38 operating testing sites, and we are establishing assessment sites with more to come in the next few weeks. Next slide, please. Our population health strategies include prioritizing population groups for testing. That includes people who are admitted to hospital with respiratory illness, for people who are healthcare workers and first responders, providing care and services to people in the community, and to people who are residents or providing services within long-term care facilities or other congregate living situations to help us identify and respond to outbreaks quickly. We have strategies that will protect healthcare workers and first responders, which are a population group both at risk of disease because of the type of work they do, but also we know that they may be at risk of exposing patients and clients to COVID-19 through asymptomatic transmission, and we need to mitigate that risk for everyone. To that end, we've implemented screening in long-term care. That includes healthcare workers and visitors to the facilities for compassionate reasons. And we're partnering with communities and across sectors to ensure that supports and services are available to people who need them, healthcare, but other supports and services as well. And we are strengthening messaging that promote health through health education, such as hand hygiene campaigns, other health promotion messaging that attends to the differences between population groups so that we are promoting a message of health, inclusion, and resiliency for all. Next slide, please. So as we move into the next weeks and months to come, we need to remember that all of these measures need to be sustained to be effective. We know Saskatchewan is early on in its path and response to COVID-19. We need to be staying strong and healthy by caring for physical, mental, social, and spiritual health, to be resilient as individuals and as communities. And we need to keep learning and understanding and removing barriers that are preventing people from taking the necessary actions. We do know that the pandemic will continue for weeks and months to come. We may not see the whole picture or understand its full impact until it's over, but we need to be tracking these direct and indirect impacts as we go forward and building that into our planning and response. Next slide, please. So our strategy, as described, includes both offensive and defensive lines. The containment and delay will help us prevent community transmission, and population health promotion will strengthen community and individual resiliency. Our defense includes mitigation strategies to ensure health care services are available when and where needed most. I think my takeaway is that the language does matter. We are all in this together. We are all playing for the same team. And we will all be affected by how well we pull together. No health system in the world can bend the curve alone, and we need the sustained support from the public to bend that curve. Thank you. I'll turn it over to Derek now.
Thank you, Dr. Krasnowski. So we just saw a walkthrough of the offensive strategy and things that are happening in order to flatten the curve. And currently, our system has been preparing a defensive strategy, and that's focused on our acute hospital services. In formulating our plans for our acute response, we have a number of principles that have guided our actions. We need to be able to meet the needs of the province with the goal of minimizing loss of life by increasing capacity to provide care. While we're doing that to respond to COVID-19 patient demands, we must also ensure continuity of essential and urgent health services be sustained for non-COVID patients. We know that there are disruptions to what we would consider normal health services delivery, and we've already seen that with a province-wide slowdown of a number of service areas. This may often mean alternate service delivery methods such as virtual care that was mentioned previously. Our response will be staged according to increases in demand. We intend to cohort, which means bring together in consolidated locations COVID-19 patients as much as possible. This may be at the unit level or ward level within facilities. It may also be by designating facilities as COVID-19 hospitals. We will also establish field hospitals where our patient demand exceeds the capacity of our facilities. Ethical decision-making will be important and guide us through all aspects and phases of the pandemic, and it will be based on the SHA ethical framework. We will need to deploy staff and physicians to other facilities to support care. Our healthcare worker workforce is so essential to being able to respond to this situation. Safety and infection prevention and control will guide our work throughout the response. And this is a provincial response. It's not by facility or siloed within areas or geographies. We are going to manage this through centralized bed flow coordination, air traffic control, like coordination of patients to ensure that they are seeking and getting care in the right and best locations. A few highlights from our defensive strategy to mitigate the spread of the disease. We are pursuing ongoing implementation of province-wide slowdown of non-essential, non-urgent services, and so far that has freed up more than 1,000 beds across our acute hospitals. We are planning a staged expansion of acute care capacity. This is phased to align with the demand as it walks through the doors. This will allow for up to 57% increase in acute beds as needed. Intensive care beds will also increase from the current 98 ICU beds up to over 900 beds as needed in the response. Supply chain is a critical enabler to managing this continued health services delivery through this situation, and preservation of supplies figure prominently in all of our planning work. Labor pool management will also be important in order to coordinate the flow of the right healthcare workers to the locations where they're needed in order to support our response strategy. We have established dedicated spaces to cohort COVID-19 positive patients, and we are creating designated COVID-19 and non-COVID-19 hospitals in response and stage to the demand, as well as mixed hospitals. And mixed hospitals would see patients that would be COVID-19 positive and those that are non-COVID-19 patients. We will also be creating additional community treatment capacity to manage the surges in demand. As we contemplated and approached the planning for this significant response, we took the modeling scenarios that Dr. Bazran presented, and we established two scalable planning scenarios. The first scenario is what we call our planned capacity. And we established a number in terms of how many beds and intensive care beds would be required based on an estimate which fell between the higher range and the mid-range modeling scenarios. Those targeted capacity numbers have basically been the numbers that we're planning to, and we're actively activating those spaces now in a staged way that will be applied based on patient demand that walks through the doors. The second scalable planning scenario that we've developed is for contingency capacity. And this is aligned with the higher range estimate that we saw in the modeling numbers. We're not activating contingency capacity at this point in time. We have plans to do that, but we would only start ramping that up if we saw an indication from the environment that would suggest that we need to scale up beyond our planned capacity levels. Our current capacity has been significantly impacted by the service slowdown that has been applied across the province. And you can see this in both the ICU numbers and acute numbers. This graph depicts down the left side the different areas, geographical areas, and in the total running along the bottom. It includes our average daily census for both ICU and acute, the current capacity, and then what is available in the system right now. And so for ICU current state capacity, we currently have about 41 beds available to meet immediate demand. In terms of acute beds, we have over 1,000 beds available in the system right now to meet immediate demand that may arise. Our surge capacity has been broken into intensive care spaces as well as acute care. So this slide depicts the intensive care potential demand, again, with the areas and on the left and the total for Saskatchewan. So based on our current daily average census of 57 people and a potential scenario of up to 833 COVID positive patients, we are planning to accommodate 890 total ICU patients at the peak of a surge. We have established plans to activate up to 963 ICU beds, which would account for that peak number. I also want to draw attention to, you can see the differences between Regina and Saskatoon compared to the north and rural. Regina and Saskatoon have scaled up their ICU capacity to allow for the admission of patients from the north and rural once they are exceeding their capacity. This is the coordinated provincial approach. And I'll also say that patients will be load leveled across the system as well. We wouldn't wait till one location was over capacity if there was space elsewhere in the system in order to ensure that we're providing this safe quality care and response. Planned capacity for acute care, the graph is laid out in a similar way where we have a current daily acute average census and in a potential demand situation of almost 2,000 acute patients from COVID-19. And so the planning figure that we are pursuing for Saskatchewan is about 3,300 acute patients at the peak. We've established a plan within our existing facilities by expanding into different spaces where we could accommodate almost 3,200 patients, which, as you know, is short of what we could anticipate at a peak. And therefore, we've identified the need to establish 2 field hospitals to address this additional capacity. And we will be activating a field hospital in Regina and one in Saskatoon in order to give us the additional space in order to allow for the patient demand at the potential peak. Ventilator capacity is of utmost importance, and you can see that from other jurisdictions. We currently have 450 ventilators available to meet the modeled demand for both the low and the mid-range scenarios that Dr. Razran presented earlier. So we're able within our existing capacity to certainly meet the 2 of the scenarios that were presented. We have identified a planned ventilator requirement of 860 ventilators to meet what we might anticipate at the planned capacity levels. So this creates a gap of 410 ventilators. We have placed multiple orders working with the Ministry of Health for ventilators, and we have actually confirmed orders for 200, with 100 of those expected to be delivered in the next 2 to 3 weeks. We are working with the Ministry of Health as well as the federal government and vendors in order to ensure that we're able to close the gap and that we're prepared with the right amount of ventilators. I'm going to provide a walkthrough of the integrated health area plan to give some indication of what people might be seeing across the province as we start staging the implementation of these plans and rolling things out. It's important to emphasize that the SHA is pursuing a staged response to demand. So that means that you're going to see different facilities that might be identified as a COVID hospital or a non-COVID hospital. Those designations wouldn't be activated at the flip of a switch immediately. We need to step it based on the demand. We are going to use existing capacity that's been identified in the system already based on the slowdown first before we start expanding into that additional capacity. We will be cohorting COVID-19 patients on designated units within facilities. This is essential to successfully limiting the risk of transmission of the disease between patient populations, and stringent infection prevention and control standards will be applied in doing that to ensure safety. COVID-19 hospitals that are identified will initially act as a mixed hospital. So they wouldn't be, again, they wouldn't be occurring overnight. It would be in response to an increasing census of COVID-positive patients in one of the mixed hospitals before they may be transitioned to COVID-19 designated hospitals. The bottom of the table provides I guess a bit of an illustration of, you can see the demand curve, which roughly mimics what Dr. Bazran presented in the modeling situation, and in the steps in capacity increases. And as depicted here, our intent is to be continuously monitoring the environment and be able to step increase our capacity just ahead of the demand so that we're always prepared for what might be coming. Each of these specific integrated health areas have a plan to respond. This slide shows the integrated northern health. We have identified a staged response to increased demand through a combination of mixed hospitals as well as non-COVID hospitals. And you can see in the map those locations that are identified to be mixed, where they would see both COVID positive as well as non-COVID patients. And then also those facilities that would be designated as non-COVID hospitals. So they would not admit COVID-positive patients. Those COVID-positive patients would be transferred and moved and admitted in other facilities that are admitting COVID patients. There are no facility closures. Field hospitals have been identified as a potential contingency for the north. However, at this point in time, we're not activating any field hospitals in any of the northern centers. In the integrated rural area, we have planned a staged response to increased demand through a combination of COVID and non-COVID facilities. There are no facility closures. We are temporarily converting some hospitals to support alternate level of care patients, and this will occur over the coming 4 to 6 weeks. This is an immediate measure that we're taking to accomplish a few key activities. So the first one is that we want to move patients, alternate level of care patients that can adequately receive care in these identified hospitals and flow them out from where they may be in tertiary and regional hospitals. This will allow us to create further capacity in those centers. Part of this conversion will include the temporary suspension of emergency department services in those identified sites in order to support reallocation of staff to higher needs areas. It's really important as we take, for example, our, nurses and physicians from those emergency departments, we reallocate them to support another site that is preparing for a surge. It's important for those staff to have the opportunity to be properly oriented to those new departments that they would be working in, in order to safely be able to support provision of care in those new environments. No field hospitals are contemplated in the integrated rural area because there is a capacity within the facilities already. This slide just depicts a bit more of a breakdown, just because of the difference in terms of some of the sites that have been identified for conversion to alternate level of care patients that will be occurring over the next 4 to 6 weeks. As I mentioned, that will result in the temporary suspension of emergency services for those 12 sites. Other sites that are noted here as COVID-19 hospitals and non-COVID hospitals, those designations will not apply immediately. They will be staged. So as patients are admitted into some of the centers that are identified here as COVID-19 patients only, right now and for the next number of weeks and maybe months, they would probably operate as a mixed hospital where they would cohort COVID-19 patients and they would also have non-COVID patients in their facility. Their emergency departments remain open and functioning as per normal. Non-COVID hospitals, they would also be staged to stand up as needed in response to demand. They would be admitting non-COVID patients, and the emergency departments in those facilities identified here as non-COVID, they remain open and operational. Ambulance services carrying COVID patients would bypass those locations, but they certainly would still be able to see patients that would be a walk-in basis. So any changes to services for non-COVID hospitals and those identified here as COVID hospitals, those would be activated in a staged manner, and there would be communications shared with community municipal leaders as well as with the community itself and the public in advance to give notice of any changes to services. In Saskatoon, we have planned a staged response to increased demand using mixed hospitals that will serve COVID and non-COVID patient populations. Patients will be cohorted on units and by floor in order to ensure safety and infection control standards are being met. We are looking for additional space in the community in terms of our long-term care facilities to allow us to move patients out of the hospitals where they can receive those services appropriately in other environments. We have planned a field hospital for Saskatoon as noted. In Regina, this is very similar to Saskatoon, where we have a staged response to increased demand using mixed hospitals to serve both COVID and non-COVID patient populations. Patients will be cohorted on units and by floor, as I mentioned previously. We will be accessing the Wascana Rehab Center for non-COVID patients where their needs can be met there safely and appropriately. We are also expanding into the community to look at long-term care facilities for other potential capacity to move patients where they can receive appropriate care in those locations. We have planned a field hospital in Regina, and I'll just note for the field hospitals in Regina and Saskatoon, we will be moving forward immediately with the activation of those sites in order to prepare them for potential surge. In summary, I want to just highlight the modeling information that has been used to help us plan to these levels. As mentioned by Dr. Bazran, those are not meant to be predictions of the future, but they are important to inform our planning, and in both from an offensive strategy and what we need to do in the public health and community areas, but then also to inform what capacity we need from an acute perspective. Our offensive strategy, we are working hard in the health services to be prepared and to do as much as we possibly can to flatten the curve. However, the public response has the absolute biggest impact on the outcome and the success of this offensive strategy that can't be overstated. Our defensive strategy is directly impacted by that. The number of patients that show up and require acute services or ICUs and ventilators is absolutely linked to our success and the public response success of flattening the curve. We're all in this together. The SHA is working with our partners to ensure that we're as prepared as possible to any demand that may be coming, but we certainly need the help of the public in meeting this challenge. I'm going to turn it over to Dr. Susan Shaw, our Chief Medical Officer, for comment.
Thank you, Derek. I want to add some very quick closing remarks. There was a significant level of detail in this presentation, and I want to bring us back to the most important and unifying key message from all of this data. As Dr. Basran stated, the most important variable for saving lives and protecting our healthcare workers is your ongoing commitment to the public health measures, including self-isolation when directed, practicing physical distancing, effective hand hygiene, and staying home whenever and wherever possible. We cannot change the virus, but we can control how the virus spreads. Following these practices will save lives, and it will protect our healthcare providers to ensure that we are there when you need us. I practice clinically as a physician. I work regularly in 2 intensive care units in Saskatoon, looking after some of Saskatchewan's sickest patients. I see the worry and concern on the faces of the people I work with, yet they and we come to work anyways. Normally, we are here to help you, and now we need you to help us. I'm asking you to continue to do what you've always done as Saskatchewan people. Come together in a time of need. This message is for every resident of Saskatchewan. You have the opportunity to save lives. Please take it. Thank you.
Thank you, Susan. We're going to move to the question and answer portion of the day. We are aware that there are a number of people on the line, but as this opportunity is intended for the news media, those outlets will receive preference when asking questions. There are a number of ways to ask questions this morning. If you're in the room, you can give me a wave and I'll call upon you. If you are on WebEx, there's a little digital hand next to your name on the right-hand panel of your screen. You can click that button. We'll call upon you, unmute your line, and you'll be able to ask your question. The third way is to enter your question into the chat box. I also wanted to let everyone on the line know that today we're going to be answering questions of a provincial nature. We also have a local spokesperson opportunity on Thursday morning to ensure that the specific local questions related to specific communities can be answered the best way that we can. So I'll start then with questions in the room.
So I know that these are what-if scenarios that are not predictions, but based on the way that our current cases are tracking, are you able to give some sort of estimate, however broad, about which scenario we are tracking closest to and what is the most probable case for Saskatchewan?
Well, we hope that we're actually in that lower prediction or lower planning tool scenario, but it's actually much too early to know. We have had the advance warning of watching the rest of the world. And I think why we have to be planning so purposefully that while we hope that we're tracking on the low case scenario, there are signals around the world, and including in Canada, that we have to be paying a lot of attention. And so too soon to know, but we do remain hopeful while still also planning for all what-if scenarios.
And I'll take a follow-up if I can. I didn't see any information here about the likely duration of the pandemic in Saskatchewan, and I know some other provinces have provided that. I think that Quebec gave an idea of what their likely peak would be. Are you able to provide any sort of sense to the public about what we're seeing in terms of when this could peak and when we might be able to consider relaxing some of the measures?
The question was related to when we might be able to see the peak and anticipate some of those measures relaxing.
So, and I would say, just to reiterate what Susan has said, at this point in time, we just don't have enough data that's going to tell us exactly when we're going to see that peak or how long. But I will say, and you've heard it reinforced time and time again in today's presentation around, we believe the public health measures that are in place are making a large impact, and if they continue to do so, that will flatten the curve. But it's important for everybody to understand, the more you flatten the curve, the longer we stretch this out, and that's intentional. It's so we avoid those peaks that we've seen across the world where healthcare systems are completely overwhelmed by COVID, and not just the COVID patients, but the non-COVID patients are not receiving healthcare in the same way that they should be because of that. So at this point in time, we don't know. But I will ask Jenny if she has anything to add. Or Julie.
Yeah, thank you. No, I believe you and Susan answered the question as I would, that it is early. We have some optimistic signs, and our hope is certainly that we are on a better trajectory than our what-if scenarios. But at the current time, we do not have enough information to be able to know for certain, and it's important that our health system is ready. We've seen in other jurisdictions where it rapidly came upon them, and with the not only mortality and morbidity associated with COVID, but additional deaths due to a system that wasn't able to anticipate and be prepared. So it was very critical for us to ensure that we are ready and that we have a sense of the scope of the potential issues.
Can we take a question from the news media on the line, please?
Sure. I have a question from Stephanie Taylor with the Canadian Press. Stephanie, I'm going to unmute you now.
Can you hear me?
Yes.
Yes, we can.
Okay, I just want to ask again, because other provinces like Alberta have been able to say when they think their social distancing measures can be relaxed. So why will you not tell people, even on an estimated basis, people are smart and understand that things could change and this is a fluid situation, but why not tell people at least how long these social distancing restrictions need to be in place for? Because that's kind of the main question people are asking at this point.
Well, I think it goes back to we're actually following behind Alberta in terms of how the pandemic or the virus has spread into their population. We're fortunately behind them, which allows us to watch and learn from them. I think in a few more weeks, as we get to the same point in the data and the experience, we'll have more ability to offer some input into what that could look like. But those are decisions actually made by the Chief Medical Health Officer. So it would be based on the experience within the public, it would be based on the data available at that time, and then working really to support the Chief Medical Health Officer as he makes good recommendations to the public.
Can we have another question on the line, please?
We have a question from Lisa Stick with EJME. Lisa, go ahead.
Hi, can you hear me?
Yes, we can.
Okay, thanks. The first modeling that we saw about 2 weeks ago said that the virus would almost certainly overwhelm the healthcare system, and the modeling that we saw there is that a situation that we're still looking at? What does this modeling say about how well we're going to be able to deal with this?
Well, I think as we presented today in the analysis with the three scenarios, all three of the scenarios project different levels of caseloads and different the acute care needs for the system. And we are preparing for the worst case scenario. So with respect to what's changed, we have got more data over the last couple of weeks, and we have done some remodeling, which have refined our planning. And it's one of the other reasons today why not only have we built that capacity into the system to respond to what we feel is likely the next phase, but we've also created a stage approach to gear up the rest of the system across the province to deal with the COVID-19 cases we may see in a stepwise fashion.
There's another question in the room.
I've just done some kind of preliminary calculations here, and I see that the death rate that you're estimating based on cases seems to hover at around 2% or so. I know that there's been widely differing fatality rates in the world, even between the three countries that you chose to model based on. How did you come to that death rate, and is there a chance that it could vary substantially from what you've expected?
This question is related to the death rate and how that might have been calculated. We'll answer that in the room to start.
So I actually think Jenny would be the one to answer that question.
Yeah, so each of the models run scenarios based on the evidence that we have available around COVID-19. So the published evidence coming out of Asia as well as Europe to look at the number of patients that would develop COVID-19 as well as their clinical journey and those that would die. So through each of the models, Dr. Osgood's models are actually quite mature, and they have accounted for additional variables such as variables around spread, variables around the number of people and when they would need ICU and when they would need to be ventilated and those that would survive from ventilation. So each of those parameters are calculated and providing some input into the potential rates of death that would occur if we were to follow that curve with that particular scenario. Again, we don't know that that's going to in fact be the case in Saskatchewan, and our sincerest hope is that that isn't going to be the case, but it is something that from a health system point of view, we do need to plan for. In other jurisdictions, we have also learned that where they were not able to prepare, that additional deaths occurred as a result of not being prepared. So the numbers are to give us a what-if scenario. They're not to say specifically that that's what's going to happen in Saskatchewan.
And just one quick follow-up. I saw that our best case relies on the Wuhan, reproductive rate, and they achieve that through extremely restrictive measures. I'm wondering if we can get there without adopting those kinds of total lockdowns, expansive testing, temperature checks at apartment buildings, like those sorts of extreme measures, and whether more restrictive measures could lead us to get even lower than that 3,000 death estimate that we're predicting or that we're modeling.
So the question is related to scenario 3 and the fact that the Wuhan experience had significantly extreme measures in order to achieve the numbers that they saw. Is there a way that Saskatchewan can achieve that same success without those restrictive measures?
I think it's a lot of what ifs, and that's the challenge of a model. I think that we can actually in Saskatchewan, and we are considering, again, with the Chief Medical Health Officer's leadership, having conversations about what does further expansion of testing look like, what do further measures that could be taken within either the healthcare system or into the general public. And those are all, I think, being considered. I do think that we have advantages. We know that our population is more dispersed compared to the density of a major urban center within China. We also can recognize even the fact that our spring break happened in February rather than March means that people were out of the province at a much better time than for our partners in provinces like Ontario or Quebec. So we do have advantages. Again, that's why it makes it so hard to directly apply. But again, they're planning tools. We're not saying this is going to happen. We're saying that we need to plan, work as a collective, as the public, to do everything we can to prevent the spread, and while the system prepares to be available.
We have just a few minutes remaining. Can I take another question from the news media on the line, please?
Jenna, I have Mark Smith with CTV. Mark, you're unmuted.
Just wondering how confident the SHA is that we'll get the needed ventilators to fill that capacity, and you said that you're expecting them in the next few weeks. What exactly is the timeline there?
Well, the timeline is exactly as it's outlined. We've presented in the deck how many we have on order we've been told that are coming. The time frame around at least the first 50% of those are 2 to 3 weeks. Just to remind folks that right now we do have more ventilator capacity than we need. We only have a small number of patients in hospital and 2 in ICU. So with respect to our ventilator capacity over the next couple of weeks, I think it's fair to say, without knowing exactly what's going to happen, unless there's some kind of fundamental logarithmic growth in the province for hospitalization, we're in good shape awaiting these ventilators. We know also our partners in BC who were out ahead of us with this over 3 to 4 weeks. They just received some of the ventilators that they were expecting as well. And again, the capacity that we've already built in the system is what's going to get us through the next few weeks. But certainly as we edge towards the peak of the epidemic, we believe we'll need that capacity, and we believe it's going to be here when we need it.
Is there another question on the line, please?
I have Lisa Schick with CJME. Go ahead, Lisa.
Hi. So you have in there that you're going to increase contact tracing capacity by 300%. What does that mean in terms of numbers of actual people doing contact tracing?
So I'm going to turn that over to Julie, but I just want to clarify is we already have increased the contact tracing by 300%, and I believe through advice through the Chief Medical Health Officer and also our staff in medical health, that would continue. Today, we're not having struggles following up on contact tracing, but we want to build more capacity as the pandemic evolves. But I'll ask Julie if she has anything to add to that.
Sure, I can try to add to that. Agree and want to emphasize the point that at this time we are meeting the increased demand for contact tracing capacity. We have redeployed staff from elsewhere in the system to assist with that work. What we are planning for going forward is also looking at the processes around case investigation and contact notification. We're looking at ways of also mobilizing the surge capacity to where it's needed most in the province. We have had experience where there are either large case investigations or cluster events, and we are looking to be able to mobilize that extra capacity to assist when and if those events continue to occur. So those are all parts of the strategies of a comprehensive community surge capacity plan as well.
Linnell, can we take another question, please?
Sure. I have Graham Condo from Access 7. Graham, go ahead.
Hello. I just wanted to ask about the capacity issues for scenarios. If Saskatoon has the most number of cases so far, if they, in say the worst case scenario, they exceed capacity, what would happen then? Would those who need acute care have to be transferred to other hospitals in other regions?
So just to reiterate, in the presentation today, Derek referred to the concept of load leveling, and that's exactly what it means is if in fact throughout the response and the staged approach to increasing capacity that we had a facility and that facility was in Saskatoon or Regina or anywhere else, we would be able to look at our provincial capacity and yes, patients would be moved to the appropriate care setting to level load and make sure that we weren't overburdening any one facility. I'd also highlight that part of the strategy is to ensure that we're not getting to the point where we have a facility that is actually jammed to capacity, and we would actually intervene before that and have patients redirected to other facilities where they can be appropriately cared for. Derek, I don't know if you had anything to add to that.
No, I don't have anything to add. Thanks, Scott.
We'll take another question on the line.
We have a written question from Brandon White with NBC News Radio in La Ronge. He asks, are we going to have access to more detailed modeling data for each provincial region? For example, North and Far North. It seems as though the projections are from 14 to 37% of infected and around 2% mortality. Can we assume this across all regions, or will there be different numbers for different regions according to demographics?
So from a planning perspective, using the modeling, they were split up across multiple areas across the province, but I think I'll ask Jenny to answer that question with respect to specific to the north.
Yes, thank you. For this modeling that we did currently, it was at the provincial level, and we divided it into the 4 areas for planning. The models are, as I mentioned, continuously being updated and adapted, and so the current process that's underway as we're speaking is actually to put age demographics into the model to give us a better understanding with the age distribution, the impact. As well, we're looking to look at ways of incorporating some of the chronic diseases that we know have been associated with higher mortality to go into the model. It will also provide us some more detailed information. The Computational Epidemiology and Public Health Informatics Lab under Dr. Osgood has a lot of experience as well with how different people interact with each other in different parts of the province from some of their previous experience with diseases in the past. And so we will be applying that knowledge as well to the model. So these are ongoing adaptations to the modeling to provide even a further maturity in our ability to support the model.
Can we take another question from the line, please?
I have a question from Carol Thompson. Carol, please identify which media outlet you're with. Go ahead.
CJWW. And my question is just wondering why the COVID patients wouldn't go straight to a field hospital as opposed to a shared hospital facility, considering Italy's experience where they say it contributed to their death toll.
So I'm not sure I have the connection to Italy that you're referring to, but field hospitals are set up, like they said, in the field. They're not actually a physical hospital. They have all the healthcare providers. They have the equipment that's appropriate for the type of people that would be there. But the most sick patients with COVID should be in a tertiary care or a regional center that's been prepared to be able to provide the type of therapies that type of patient would be required. So I think it's too early to be able to say specifically what types of patients or what the patients within a field hospital look like, but we do know that we need to start planning setting them up. The goal is to not need them and to continue to use the current hospitals and facilities all across the province to maximize responsible use of the resources.
We'll take one last question from the room and one last question on the line. So in the room, please.
So I've just noticed that these what-if numbers, once again, seem to be similar to jurisdictions that have substantially higher populations than us. So first of all, the Wuhan case in scenario 3, we have about 3,000 deaths. They had the same, but they have 11 million people. Our estimates are similar to Ontario's, yet they have 10 times the population. I'm just curious why that discrepancy.
So I think we'll get Jenny to answer this question. The question is related to the scenarios that were chosen and the regions in which they were off of were from high populous regions. How does those transfer to the Saskatchewan experience, given they have so many people in Wuhan or in Italy, for example?
Yeah, thank you for that question. So I think there's two factors here. One is certainly the experience in Wuhan is very different than what we're experiencing here currently in Saskatchewan. They were not aware of the virus. They were the first to become aware of that virus. And then when they became aware and mobilized interventions, they were quite aggressive interventions, including bringing in 40,000 healthcare workers from around China and equipment and building 2,000-bed hospitals very quickly. And so the situation there was very different than ours. Italy as well, there's some variation in the response experience. So the direct impact will be very different because their interventions were different, and we are learning from that and hoping to avoid some of that. The second piece around the modeling in regards to some of the differences in the numbers that are suggested across the province is that we don't have a direct comparison. We don't have detailed modeling information from our colleagues across the country, although Dr. Osgood is part of the Public Health Agency of Canada Expert Modeling Committee, and this model has been reviewed by that group several times. The way that the models work, and within Dr. Osgood's lab, for instance, there's 5 different types of models that, depending on the question that the models are being asked, it provides the type of answers that are required. And so we don't know what type of modeling was used in other jurisdictions or what they were asked to provide answers for. I can say that, again, that Dr. Osgood's models are very mature, and he's been working at them almost as soon as the outbreak was identified in Wuhan. And the question that we worked with Dr. Osgood's lab on was really to say, what if this situation were to happen here? What do we need to plan for, and how do we need to be prepared, both from the offensive and the defensive approach? And that has helped drive some of the direction that we're going. And as I've indicated earlier, that it isn't a predictive model. That wasn't the purpose of our modeling, and it was really to help with the planning and hope that we are, changing our path to a very different path that the models have shown so far.
We'll take one last question from the line, please.
I have Alicia Bridges. Alicia, please identify your media outlet. Go ahead with your question.
We can't hear you, Alicia. Okay, well, let's go to the next caller and we'll come back. Linnell, are there any more questions?
I have Laura Woodward. Laura, please identify your media outlet. Go ahead.
Hey there, I'm with CTV News. And
ahead.
I have a question just about the duration of time when it comes to these infection rates and deaths that we're planning for in a what-if scenario. Over what duration of time can we expect these deaths?
Well, I think that cycles back to the earlier questions where we discussed it's too early, where we are luckily right now at the beginning and it's staying flat for now, and where we remain cautiously optimistic that this is what we hope to see continue. However, we have a responsibility to be planning for what ifs, and while it's too early to know exactly what's going to happen next, we do know based on what the Public Health Agency of Canada, what the Premier and what the Prime Minister have said, that we should anticipate for weeks to months, and we're not able to be more accurate, I think, within Saskatchewan beyond that at this time.
Can we just circle back to Alicia Bridges? Can you try asking your question again, Alicia? Okay, with that, I think we'll close the session today. Just a couple of reminders. The news release and also the presentation that you saw today is on the Government of Saskatchewan website. And also for questions or media outlets who are curious for specifics related to specific communities, there will be a media availability tomorrow morning to ask questions of either Regina, Saskatoon, the North, or our rural areas of the province. Thanks very much.